Welcome to this series of videos related to curriculum development in health professional education. My name is Mohamed Hassan Taha. I am a medical educationalist with the passion to advance health professional education in order to improve the population health. This video is part of the series of videos in the domain of curriculum development in health professional education. And in this video, we will be talking about apprenticeship, community-based education, and longitudinal clerkship in health professional education. The learning outcome of this video will explain the historical apprenticeship model, analyze the existing trend in curriculum planning toward authentic curriculum. We'll discuss also community-based education, longitudinal clerkships, and workplace learning, and identify the pitfall for optimizing the different strategies throughout the video. So the apprenticeship models, which is previously used before flexional report and flexional area, student apprentice to practicing doctor or to practicing practitioner, health practitioners, and students learn through supervisions and limitations. And there is informal transmission of professional secrets, and there is no structural curriculum. And education was experiential but variable in quality. And the limitation of this approach, there is a lack of scientific grounding, and there is no formal curriculum, inconsistent supervisions, and variable clinical exposures, and limited theoretical foundations. And the result, shift toward university-based medical education. Then, in the last century, medical education shift toward university-based education, emphasis on the scientific medicine, structure, curriculum, classroom, lectures, even the accreditation become process-based. And the hospital remain the main site for the training. So in such type of the curriculum, unfortunately, most of the medical schools, they are facing the same challenge. The clinical exposure becomes secondary to the theory. So the concern now over removal from the clinical setting to the classroom. There is a loss of authenticity and reduced workplace immersion and clinical training. And the current trend now to return to learning in workplace. So taking the positive aspect of the apprenticeship, but with the new concept, and embedded this practice, clinical practice, in the curriculum, and carefully monitor this. So now there is the call for shift of the curriculum from theory to practice, from hospital-based to community, from short block to a longitudinal experience, and this will lead to authentic curriculum. And the authenticity should be the central goal when we think about any curriculum development, design, implementation. Let us define what is the authentic curriculum. Authentic curriculum means using real patient problems, real responsibility, real professional roles, and learning embedded in practice rather than the simulation alone. One of the authentic approaches is the community-based education, where medical education or health professional education outside the tertiary hospital. And the common sites for the general practice, including the primary health care, the rural clinics, community health services, and positioned toward it is positioned the medical education toward the seaside in the spicy continuum approach. And some people confuse between community-based education and community-oriented medical education. You will find the detail related to the comparison between both in the social accountability videos series. So you'll find a detailed video describing in detail the difference between community-based and community-oriented education. So community-based education, learning or location outside the tertiary hospitals, and the community-oriented medical education design, it is approach designed to teach about the community health and community center approach. It's not only community medicine or community health approach, but the concept of community And health is a central goal in community-oriented medical education, not only the clinical practice or treatment of disease. It may include a hospital or community component, and it's very important distinction between them. So why community-based education? To have adequate exposure to the community, have holistic perspective, understanding of the social determinant of health, development of professionalism, development of cultural competency, and development of the teamwork skills. And no, most importantly, also supports the development of professional identity. Community placement help the students form their doctor identity for medicine and for the other professions, nurse identity and other, develop patient-centered orientation, understand the continuity of the care not only in the tertiary hospital, appreciate the social contract between us as clinician and the patient and the community, and identify formations occur through the experience. And also it has impact in the workforce and the capacity implication, because community placement provide additional training slots, reduce hospital overcrowding, expand clinical teaching capacity, and support rural workforce development. And there is a very useful experience, such as the rural clinical schools in Australia, which play a lot in enhancing the students with and doctors and physicians and clinicians and nurses with the community experience, and also support the advancement of healthcare system there. So students perform as well as better in the exams as well as in their future career. Community oriented education can occur, and basic education can occur in urban primary care, rural clinical schools, and remote healthcare. Basically, it's outside the tertiary hospitals, and evidence suggests that they perform better than those who study the classical approach. It's very important to center planning as a determinant for quality here. And key implementation issue is have clear outcomes, planning for assessment, stakeholder involvement, faculty development, having good access to facilities, maybe for internet, for telehealth, telemedicine, it can be also used, having a good study guide, mentorship, and we should encourage medical teachers to use it. One of the approaches that is also need to be considered for curriculum design and curriculum development is longitudinal integrated clerkship. The longitudinal integrated clerkship it's relatively new, but it's very important concept that need to be considered when designing a curriculum for the clinical phase. What is the problem with existing and with the current clerkship? Traditional block rotation clerkship is a short duration, limited continuity, specialization focus, fragmented learning, and limited responsibility of the student, and students seen in a short period of time. The core feature of longitudinal integrated clerkship, it supports the students to have a continuous patient relationship, continuous teacher relationship, integrated multidisciplinary care, active team participation, and expanded durations up to 1 year. For example, instead of having surgery clerkship, obstetric clerkship, medicine clerkship, pediatric clerkship, and other specialty, to have students study the main concepts in a longitudinal way. For example, a patient, they can see a patient with acute abdomen, a lady with acute abdomen from medicine perspective, surgery perspective, obstetric perspective, and so on. And the educational benefit of longitudinal integrated clerkship is students in longitudinal integrated clerkship, they feel competent by study, study show that, provide patient-centered care, experience integrated learning, they develop stronger identity, and they are outperformer in comparison to traditional rotation, as shown in some studies. To implement it, you can implement it in community-based education setting, hospital-based, ambulatory care, in urban or rural area. And the key consideration here, there's a mix of patient exposure, should be aligned with the core curriculum, you have case in which they can have like presentation together from different faculty members, and also using the online platforms, the learning management system in case-based discussion could be enhanced. Thank you so much for watching this video. And now we will move to the last video of this series related to curriculum development in health professional education, which will be about curriculum evaluation and curriculum review. See you in the next video.